Lichens are primitive plants composed of algae and fungi, and planus means flat in Latin. Erasmus Wilson coined this term, probably because he thought the lesion was similar to lichens growing on rocks. Lichen planus is a chronic mucocutaneous disease of autoimmune origin, affecting around 0.2 to 2% of the population. Oral lichen planus could either accompany the cutaneous lesions or precede them. Stress and anxiety are known to be significant factors in inducing this condition. There are reports, however, stating that this could be anecdotal and that it lacks enough evidence. Reports of an association with hepatitis C have appeared in literature, usually from the Mediterranean countries, but more recent epidemiological studies do not support this association. A variety of drugs and other foreign bodies may elicit a host response to induce these lesions in the oral cavity, but these lesions are better designated as lichenoid mucositis or lichenoid lesions. So ultimately, no one yet knows what causes this disease, but it's generally considered to be autoimmune in nature. Most patients of oral lichen planus are middle-aged with a male to female ratio of around 2:3. Oral lichen planus manifests in a variety of clinical variations, namely the reticular type, the atrophic or the erythematous type, the erosive or the ulcerative type of oral lichen planus, the plaque or hypertrophic form, and the bullous form of oral lichen planus very rarely. The reticular form of oral lichen planus is the most common type, manifesting frequently in the buccal mucosa, bilaterally and symmetrically. It also occasionally manifests on the tongue, gingiva, and the lips. It is characterized by numerous interlacing white keratotic lines or striae called Wickham striae, and is usually asymptomatic or presents with minimum clinical symptoms. This form of the disease usually presents as red patches in conjunction with reticular striae and with the erosive variant. Patients may complain of a burning sensation and discomfort, and this manifestation of the lesion usually appears on the gingiva, producing a pattern called desquamadogingivitis. But this term is not strictly reserved for oral lichen planus and is rather a vague, broad clinical term that includes other conditions like pemphigus vulgaris, cicatricial pemphigoid, epidermolysis bullosa, and linear IgA disease. The atrophic or the erythematous form also frequently occurs on the buccal mucosa. The erosive form of oral lichen planus manifests with an ulcer covered with pseudomembranous exudate associated with reticular striae and also erythematous patches. Patients may complain of a sore mouth and difficulty in mastication. White, raised or flat plaques may occur as a variant of oral lichen planus, usually on the tongue and the buccal mucosa. This form of the disease is difficult to distinguish from leukoplakia. It may occur in conjunction with white striae and may be an irregular to a smooth plaque, often involving more than one area of the affected site. Oral lichen planus also manifests as patchy areas of reactive melanosis in people of color due to stimulation of melanocytes by inflammatory cells. Under the microscope, the reticular and the plaque type of oral lichen planus manifest with epithelial hyperkeratosis with focal areas of atrophic epithelium in between. There may be acanthosis of the spinous layer with pointed sawtooth retipex. The immediate adjacent connective tissue consists of a band of dense layer of inflammatory cells composed predominantly of T lymphocytes, obscuring and degrading the basement membrane and infiltrating the epithelium. The erosive and the atrophic forms have the same features under the microscope, except that the epithelium is relatively thinned and destroyed by the inflammatory cells. Microscopic diagnosis can be aided by immunofluorescence, where it would be positive for fibrinogen and negative for IgA, IgM, and IgG antibodies. Clinically, it becomes very important to differentiate oral lichen planus from other lesions because this disease is classified as a potentially malignant disorder. The reticular pattern may have to be differentiated from other lesions like lichenoid lesions due to drugs, restorative material, graft versus host disease, and lupus erythematosus. The erythematous and erosive type may resemble conditions like pemphigus vulgaris, mucous membrane pemphigoid, atrophic candidiasis, lupus erythematosus, and erythroplakia. The plaque type, of course, may have to be differentiated from leukoplakia. Remember that the bilateral reticular pattern on the buccal mucosa are very characteristic. So even if it manifests as other variants, look for focal areas of white striae. But if there are isolated oral lichen planus-like lesions on sites like the ventral surface of the tongue, the soft palate, or the floor of the mouth, a biopsy is definitely recommended to rule out any malignant changes. There are two sets of criteria used to diagnose oral lichen planus. One was proposed in 1978 by the World Health Organization, and the other set of guidelines were put forth by Vandermeij and Associates in the year 2003. Criteria proposed in 2003 were essentially modified from the previous World Health Organization set of guidelines proposed in 1978. Whether one set of guidelines is more accurate than the other is debatable, but there have been studies stating the 2003 guidelines to have a less of a subjective bias. Corticosteroids are the mainstay of drugs in the management of oral lichen planus. Topical application of corticosteroids like triamcinolone acetonide, betamethasone, clobetasol could be effective in inducing healing within a week or two. However, the patient must be informed of a potential flare-up when the topical application is stopped. Antifungal therapy along with topical corticosteroids may enhance clinical results due to elimination of a secondary colonization of candida in sites of oral lichen planus. Systemic topical vitamin A analogues have also been used with a varying degree of success. Ultimately, patients may be kept under a routine follow-up due to the potential malignant nature of oral lichen planus. A good oral hygiene has to be maintained, and aversive habits like tobacco and alcohol are to be avoided.